Hello, health psychology students. I am Dr. Denise Martz. I want to welcome you to the class. If you have not already, please say hello to your class on Flipgrid. And if you haven't already, please watch my overview of the syllabus and read the syllabus carefully, especially the calendar, the structure of the class, and the study strategies and advice, particularly for a asynchronous class like this one this semester. So welcome. Plan for today is to give you an updated lecture. This will be the Intro Health Psych lecture. And it has updated coronavirus information. So I will go ahead and get started on that. One of the themes for this class throughout the semester is going to be, for many of you, this will be a class that will get you thinking a bit about your personal health and your personal health behavior. But I also know that this is an interdisciplinary class. We've got a lot of psychology majors. We have a lot of exercise science majors. We probably have some music therapy, some nutrition majors. And I love the interdisciplinary nature. I miss you all in the classroom being able to kind of share from your disciplines and your backgrounds. But many of you are going to be future healthcare providers. And so I'm teaching this class all throughout the semester with the idea in mind that as future healthcare providers or for your personal health, that human behavior, emotions, and cognition, which are our thought processes, are all intertwined. And when we get to talking about cognitive behavioral therapy, which we will be doing eventually when we do the behavior change lecture, we're going to take a look at what is called this triad. And the triad is that our behavior, our feelings, and our thoughts are always influencing one another. And so I call it the behavior dance. We're going to do this a lot this semester, just trying to emphasize, particularly in a healthcare system that is very biologically oriented. I want you all to leave this class understanding more how the psychological aspects of being a human being, how our thoughts and how our feelings, as well as how our behavior affects our health or affects our illness. Okay, giving you a little bit of background and trying to legitimize this area of science for you. I want to talk a little bit about the National Institute of Health. One of the branches of the National Institute of Health is called NCAM, and it's the National Center for Complementary and Alternative Medicine. And so this would be the center that supports good quality research studies, oftentimes randomized controlled trials, of research on either treating health or preventing illness that is not just biomedicine or biological in nature. Okay, so let's say we wanted to put together research on how exercise prevents coronary heart disease, and we're proposing this randomized controlled trial, and we would have a control group. We might have a group that's on medications. We might apply for funding through NCAM to fund our research. So let's get a couple of textbook definitions in here. Integrative medicine, and you're going to see the New Medicine documentary, which is uploaded online on As You Learn. I love that documentary because it really explains what integrative medicine is, and it has quite a few champion psychologists and champion physicians. And the championing part is bringing in this integrative medicine into the traditional biomedical medicine. So integrative medicine combines mainstream medical therapies and CAM therapies for which there's scientific evidence of safety and effectiveness. So this stuff has been studied with good science. And mental health professionals often call this behavioral medicine, where we're using behavior as the medicine instead of like medications or surgical procedures as the medicine for individuals. Complementary and alternative medicine, this is an healthcare systems practices and products that are not necessarily part of conventional medicine. And the conventional medicine in the United States would be that biomedical medical model. So using medications or using surgical procedures for treatment. Public health is the branch of medicine for public health, and it's about hygiene, having to do with cleanliness and sanitation. Epidemiology, I'm going to spend one lecture introducing you to the field of epidemiology and how it's being used in previous healthcare, as well as particularly it's really being used during this pandemic. And usually public health is focusing on disease prevention and management, and public health is tax-based funded. Healthcare insurance, so like my healthcare plan, it's a North Carolina state healthcare plan. It's a Blue Cross Blue Shield product. These are private insurance companies. The public insurance companies for individuals would be Medicare. Medicare is usually federally supported tax dollars. And Medicare pays for health insurance for people who are 65 and older, or people with a registered disability. Medicaid, on the other hand, is public health care, and it's by state. So it's not federally funded tax, it's state taxes. And Medicaid pays for health care for individuals that are considered to be below the poverty level. And keep in mind, different states define the poverty level in different ways. I think it's about $14,000. Don't quote me on this, but I looked it up a couple of years, about $14,000 a year of income in the state of North Carolina. And Medicaid tends to fund children who are below the poverty level more so than it funds adults, but it does fund some adults. So this would be the healthcare insurance for individuals. And in the United States, because we have privatized insurance, and then we've got Medicare and Medicaid, which would be government funded insurance. And then our public healthcare system is funded more by local taxes or by state taxes. Our public health and our insurance companies are not cooperating very well. They're not well linked. But in countries, and we're going to talk about our sister countries eventually, that have universal health care or socialized medicine, where the tax dollars pay for everybody's health care and people go and get their health care for free and don't have personal insurance. They don't use personal insurance to pay for their health care. The government tax base pays for their health care. Those countries, their public health and their personalized healthcare for individuals is very well linked. And interestingly, in some of those countries, they have fared much better during this pandemic because of that cooperation and that coordination. Okay, so those are some textbook definitions. Let's define the field of health psychology. So in terms of the field of psychology, which is quite old now in history, my division, the health psychology division of the American Psychological Association, is Division 38. And so I belong to this division because I'm a clinical health psychologist. It was founded in 1978, which I know that sounds really long ago for you all. Most of you in this class were only eggs back then and not even born at that point in time. But for the field of psychology, health psychology is very young. Okay, I just want you to know that. In undergrad, I didn't even have a course in health psychology. It wasn't even offered. It wasn't until I got into graduate school. Originally, I thought I wanted to be a physician, and then I got wooed into the field of psychology. It wasn't until I was in graduate school that I even realized there was such a thing as health psychology. And so in my graduate program for my PhD, I did the adult track and I did the health psychology track. And that's where I fell in love with this field, because it took all of my interests in medicine, my previous interests, and it merged it into the field of applied psychology. And so that's what health psychology is. So we study, the etiology means the causes of disease. We study causes of disease scientifically. We are here to promote health. We are here to prevent illness. And we want to promote public health policy and improve policies. So every now and then, just as an example for policy development, and keep in mind that's our lawmakers. So it could be state level representative, or it could be in Congress, our House of Representatives are the lawmakers who write and propose the laws. And then you all know how it goes through Senate and then gets approval or not approved. We oftentimes, as health psychologists, when there is a certain bill that is in the House and we think it would really benefit consumers, we lobby. We call our representatives, we email, we message, that type of thing. And so it is very difficult to be a healthcare provider. So I'm a clinical health psychologist. The clinical part is that I treat psychological illness. The health psychologist part is I also treat medical illness, and I'm interested in trying to prevent mental and medical illness as a clinical health psychologist. It is hard not to pay attention to politics when you are looking after people. So there are going to be some times, particularly when we talk about the healthcare system, we're going to talk about some of our politics in the United States, because you just can't talk about healthcare without necessarily getting into that. Health psychology tends to focus on primary prevention. So primary prevention would be doing some kind of intervention, program, treatment for healthy people to keep them healthy. So as an example, physical education in the public schools is a primary prevention intervention. It is trying to keep kids healthy by getting them exercising and keeping them healthy. We also, in the field of health psychology and primary prevention, have been very active along with people in public health with trying to prevent the spread of coronavirus. So the best way not to get sick from coronavirus is to not catch it. And that's going to involve behavior. It's going to involve behavior for us, and it involves our reliance on behavior of other people. But doing the right kinds of behavioral things to try to prevent from catching this virus. So health psychology is more primary prevention. Behavioral medicine is, again, the behavior used as a medicine as opposed to medications or surgical procedures used as the medicine. Behavioral medicine is the application of psychology and other social, behavioral, and all the way up to spiritual services that are evidence-based. This is all based in science. Okay, we're not just making stuff up and doing stuff. That would be unethical. It's based on science, just like the field of medicine. The use of medications and surgical procedures is based in science also. Okay, and it is meant to help people who are diseased. And behavioral medicine is usually focusing on capturing medical illness early, and treating it before it worsens, or it could also mean treating a medical diagnosis. But I want us to focus and pause here for a minute on the word disease. We all know disease tends to refer to medical diagnoses, but I want us to pay attention to the roots of the word, because these are individuals who are diseased. They are not feeling good. They are feeling unpleasant. Okay, so diseased. And I just want us to just focus on this for a second here, that when we are diseased, when we are stressed and we are not feeling well, that tends to promote not only mental health problems, that tends to promote medical disease. Our body is not healing itself on a regular basis. It makes us susceptible to medical illness, and vice versa. When we are medically ill, thank goodness I have not been sick this winter. I've stayed away. I'm going to knock on wood here. I have stayed away from flu and coronavirus, thankfully. But when we are sick, psychologically, emotionally, behaviorally, we are not well. So I just want us to think about mind-body interactions here, how these things tend to all intertwine, just kind of like that cognitive behavioral triad that we talked about a bit. Now, in terms of practicing behavioral medicine, certainly clinical health psychologists do this, but there are also a lot of other variety of professionals that practice in integrative medicine who practice behavioral medicine. When you watch the new medicine documentary, it's going to feature, again, psychologists, physicians who are practicing integrative medicine. We get a lot of nutritionists, a lot of physical therapists, occupational therapists, nurses, psychologists, physicians, physician's assistants. There are a lot of different types of professionals nowadays that are practicing integrative medicine. When I started out in my career in this field, it was rare to see medical practice practicing integrative medicine. And we have come a long, long way in 25 years. So far along that federally qualified health homes, and we have one here in Watauga County. It is High Country Community Health. They are a federally qualified health home. They have on staff not only physicians and physician's assistants to treat consumers medically here in Boone, but they have a clinical health psychologist with a PhD. They have counselors. They have nutrition consultants. In order to get those federal dollars to operate their clinic, they have to have integrative medicine, and they do. And the reason why there's such an incentive to have integrative medicine is because the scientific data suggests it's much more effective for individuals. And that's going to be a theme you're going to hear all throughout the semester, that biomedical medicine offers us a lot. I've relied on that in the past. My family has. There's a lot to be offered in conventional biomedical medicine, but integrative medicine is simply better. Okay. Scientifically, it is more effective, it's more compassionate, and it's better. So usually people who are practicing behavioral medicine are practicing secondary and tertiary prevention. Secondary prevention would be if people have signs or symptoms of disease, but not full-blown disease. So as an example, let's say we've got somebody who has high blood pressure, and we're treating their high blood pressure with exercise and dietary changes and some stress management, but they haven't had a heart attack and they haven't had a stroke. So they haven't had full-blown disease yet, but they do have high blood pressure, which is a symptom of cardiovascular disease. So in that situation, the exercise, stress management, and the dietary changes would be trying to prevent the high blood pressure from causing further harm. Okay. Tertiary prevention level would be when somebody's got a full-blown medical diagnosis and we are using this behavioral medicine to try to prevent. The prevent part is to prevent the disease from worsening or to prevent death. So a good example of tertiary prevention would be something like a cardiac rehab program. So after a person has had a heart attack, if they get sent to a cardiac rehab program, then they get supervised exercise. They're going to have nutrition consultation, psychologist consultation, maybe some physical therapy if they need that type of thing. So normally tertiary prevention, we tend to call in US healthcare treatment. So when you're going to get treatment for your disease, and rehabilitation would be after a pretty significant event has occurred and you're trying to rehab back into health, trying to lessen the severity of the disease. So in behavioral medicine, we're more likely to work with people with either signs and symptoms of the disease or full-blown disease when we're practicing behavioral medicine. Okay. So people who practice in integrative medicine, like clinical health psychologists, we practice out of this biopsychosocial spiritual model. And keep in mind that traditional conventional medicine focuses right here on the biology. Okay, which is why we use chemical medication, surgical procedures, traditionally conventional medicine to treat disease. But we go beyond that. And the thing that I like, this is why integrated medicine is more effective. It treats the whole person like a human being. Okay, not that traditionally physicians have treated people like human beings, but they were trained to focus on the biological aspects mainly and not focus on all of these other kinds of things. So integrative medicine is going to embrace, certainly the biology of people is important. We are composed of organs. Those organs are composed of cells. Those cells have chemicals in them, and there are physics that are operating all throughout our physical bodies. The psychological piece to it is the fact that our emotions or our affect, our cognitions, which are our thought and our thought processes. And we're going to talk a bit about, in this semester, about thought habits, that many of us get into these thought habits that are problematic, and our actual behavior. So either our lack of behavior or our actual behavior would be at the psychological level. At the social level, in this biopsychosocial model would be things like relationships. And we're going to spend at least a good lecture and a half on social support and how important relationships are. They are one of the biggest predictors of happiness in individuals, is having close connection and close emotional relationships. And then even thinking about socially our institutions. And so we are all mountaineers because I'm a professor at ASU, you're students at ASU. We might be thinking about our community, like our rural community of Boone or Watauga County. But those institutions can be important. If any of you belong to any organizations, clubs, sororities, fraternities, those would be institutions at the social level. At the spiritual level, and keep in mind, scientists traditionally don't like to go to the spiritual level. They're like, that's for priests and that's for ministers. But in this complete human biopsychosocial spiritual model, we honor that. We honor that this is a significant part of many individuals' lives. And so the spiritual piece to it would be, do people have a sense of meaning and purpose in their life? Do they have a sense of why am I here on earth? Why do I exist? Which would be existential psychology. A sense of connection, and it could be a sense of connection with God, Allah, higher power. It could be sense of connection with nature. I know I find a lot of uplifting for myself being out in nature and appreciating just how beautiful nature can be. And then all the way up to the mystical, meaning like things that we can't see necessarily, things that haven't necessarily been studied scientifically. And so this could be at a religious practice level, or it could be at simply more of a spiritual level of feeling connection with others, feeling connection with nature, feeling connection to humans and animals, feeling connection to a higher power like God. So, total human here, biopsychosocial spiritual model. Okay, we are going to go way back in time, and then we're going to come up to now. Okay, so way back in time, 1900. None of us in here were born. None of us were even eggs. I wasn't even an egg then. My mom wasn't even born at this point in time. I want us to look at the leading cause of death back in 1900s, and then we're going to go forward up into 2019 and look at changing pattern there. And then we're going to talk about what has gone on with this pandemic. So the leading cause of death back in 1900 was pneumonia and the flu. So infections and communicable diseases where infections were spread from person to person. Tuberculosis was a lung disease where it was probably a really awful way to get sick and die, where your lung just deteriorated and people would be coughing up blood. And it was an infectious disease. It was communicable, spread from person to person. Intestinal disease, it could have been communicable, but a lot of times intestinal disease was eating bad meat that wasn't well preserved, or eating foods that weren't healthy and safe to eat. And so this would be a disease process where infection would begin in the GI tract, and people would kind of rot from the inside out. Again, horrible way to be sick and to die. Heart disease was number 4 in 1900s. A lot of this is because we're going to see that coronary heart disease is number 1 before the pandemic, number 1 for men and for women as of up to 2019. But it was much lower on the list back in 1900 for a variety of reasons. Number 1, people didn't live long enough necessarily to have heart attacks or stroke. And people back in 1900s actually, they didn't have modern medicine like we have nowadays, but people were healthier. People moved a lot. They had to move a lot and exercise just to get their work done. Or if they were kind of nomadic, move from place to place. They had to move a lot to get their food. Their food tended to be vegetables, fruit, and meat. And it wasn't processed food. And so anyway, so people, and then there are a lot more sense of community, tribes and community and reliance on social connections in order to function and in order to survive. Stroke is what happens in a heart attack. In the disease process of the heart is very much like what happens in a stroke, but it's a disease process in the brain. My son asked me years ago, like, well, if we call it a heart attack, why don't we call a stroke a brain attack? And I'm like, good question. I don't know. Nephritis is kidney disease, pretty low on the list. Accidents was very low on the list back in 1900, basically because people did not move fast enough. They didn't have the vehicles, they didn't have the airplanes, they did not move fast enough. That if you move fast enough and you come to a number up top, that is really bad on the human body. So it's no wonder that people nowadays die much more frequently in accidents like motor vehicle accidents than they did back in 1900. Cancer was pretty low on the list. And again, because cancer is more likely to be occurring for most people as a function of age. And one way of thinking about that is that our cells are always replicating. And if you think about sweet little baby skin, those little cells are they're brand new and they're replicating really fast because those babies are growing and they're just got that sweet little baby skin. And then you think about older individuals getting wrinkly and different kinds of skin because they're basically their skin cells are not replicating nearly as quickly. Um, and in that process, as we age, cell replication can spin out abnormal cancerous cells. And so it makes some sense that age is a predictor of that. Senility was pretty low on the list. Again, people were leading a rather healthy physical lifestyle that kept their brains healthy, and people weren't necessarily living long enough to get senility. Nowadays, this would be things like Alzheimer's disease. And for the DSM, for mental health professionals, we would call this dementia, not senility nowadays. So it might be caused by Alzheimer's disease, but the psychological diagnosis would be dementia, which is cognitive decline. Back then they called it getting senile or senility. And then diphtheria was another infectious disease back in 1900s. Overall, what you're seeing here was a pattern of communicable infectious disease. And that changed quite a bit. So this is Center for Disease Control data. And I want us to, we're going to pause here and kind of go through some of this stuff and talk about it. These are the leading causes of death in modern times prior to the pandemic. And we don't have yet, I'm sorry, I don't have this in my lecture yet at this point in time. I'm going to talk about the dramatic change that the pandemic has caused, but what we haven't had is enough time post-pandemic for, like the Center for Disease, we're so busy trying to test people, help people with their behavior, prevent infection, so busy nowadays trying to roll out vaccines as an example. There has not been a lot of time to be able to take a look at how all of these kinds of diseases that killed people prior to the pandemic have panned out post-pandemic. Okay, so I'm going to talk about this. This was dated CDC 2014, and leading cause of death in the United States was coronary heart disease for men and for women. Now, keep in mind, most lay people think that breast cancer is the leading cause of death for women. It is not. And in fact, even amongst the cancers cause of death for women, it is actually related to smoking, and it would be more bronchial and esophageal cancers, lung cancer, that kind of thing for women. So coronary heart disease, leading cause of death for men and for women, and causing 50% of all deaths. So half of all deaths in the US prior to the pandemic, coronary heart disease, which is usually death by heart attack. Cancer, we're going to spend at the very end of the semester talking about cancer. 23% of all deaths before the pandemic were because of cancer. 50% of men and a third of women will have cancer at some point in their lives. Don't worry about these raw numbers. I'm not going to expect you to remember those. Oops, let me go back. Okay. Number three, well, first of all, I want to talk about how the number one cause of death and number two cause of death, cancer. If we look at what is driving those, 65% of the variance, so 65% of the predictability of getting these is attributable to cigarette smoking, high-fat diet. And keep in mind, diet's kind of complicated, but just simplifying it, lots of reliance on animal products, a high-fat diet. And then number three, sedentary lifestyle, which is lack of exercise. These three behaviors, we're going to spend some time on these all throughout the semester. If we had a magic wand where we could just, or a genie or a wish or something like that, we could go after one behavior at a time and change that behavior for all people in the United States. The biggest impact would happen if we could get people to stop using tobacco products. I used to just talk about smoking, but now it's smoking and vaping, okay? After that, it would be to change the way that people are eating their food, okay? Particularly our heavy reliance on animal products. The third thing would be getting people in the United States, getting everybody exercising on a regular basis, because 65% of the number one and number two causes of death attributed to those lifestyle behaviors. So here's the behavior dance. This is why in a class in health psychology, we're talking about this context of disease that kills people and how powerful lifestyle is in predicting those diseases. Number three on the list, COPD, is chronic obstructive pulmonary disease. That's mainly emphysema, and it is the lung disease where the lungs start failing because of disease process. It's normally driven by cigarette smoking. Nowadays, we're seeing COPD in people, even young people who are vaping. These are oftentimes individuals that have had quite a decline in their quality of life, and many of these individuals have to rely on oxygen just to stay alive. Number 4 on the list, the Center for Disease Control calls this unintentional injury. In the previous slide, we called it accidents. Same thing, okay? Unintentional injury or accidents is number 4 on the list. Number 5 on the list is cerebrovascular disease or stroke. And again, remember that the lifestyle and the disease process that drives coronary heart disease is the exact same process that drives cerebrovascular disease. It's just the damage here happens in the brain. The damage here tends to happen in the heart. Number 5 on the list for people in the US is Alzheimer's disease and Alzheimer's dementia. And again, our population is living longer. The longer we live, the more likely all of us would get any of these disease processes. So the best predictor, I want us to kind of back up here for a second, the best predictor of getting any of these diseases on this list, so this is all people in the US, is age, okay? Age, accumulation, particularly accumulation of poor lifestyle across time. The older we are, the more time that has had to operate, the more likely individuals would get these diseases here. Number 7 on the list is diabetes. This is increasing on the list. We'll talk about, I've got a full lecture on diabetes later in the semester, particularly type 2, which is lifestyle driven. Number 8 on the list, remember this was number 1 back in 1900, but before the pandemic, influenza, the flu, commonly called the flu, and pneumonia. Pneumonia would be the lung disease process. People don't tend to die of influenza, but if they get the flu and that converts into pneumonia, they tend to die of the pneumonia. So it'd be flu-driven pneumonia death here. So that's why they're pieced together here. Nephritis would be kidney disease, and this is, for the most part in the United States, being driven by diabetes. And then number 10 on the list would be suicide. And certainly there are lifestyle aspects to suicide. There would be untreatable psychological illness, not very healthy relationships, oftentimes with others, access to a lethal means, particularly in the US, access to firearms. And we see in rural areas, people have more firearms and they're more likely, if they make a suicide attempt with a firearm, to actually be successful at dying of suicide. And then I would also like to add here, untreated psychological illness. So one of the big pushes that we're trying to do in terms of public health is encourage individuals, if they are suffering from a psychological disorder or mental illness, to go get help. Your generation, you youngsters are experiencing more stress than any previous generations at your age range, since the American Psychological Association has been tracking stress levels. But the good thing about your generation is your willingness to go get help when you're struggling. Previous generations experienced a more stigma, self-imposed or culturally imposed stigma, and people were less likely to want to go and get help. So on the last slide, we talked about summing it up, infectious disease. On this slide, prior to the pandemic, we were seeing more lifestyle driven disease. Okay, some infectious disease, but mainly lifestyle driven disease. And if lifestyle is driving and causing disease that is killing people in the US, doesn't it make sense that we would want to target lifestyle behavior in order to treat people for illness, or target lifestyle behavior to prevent people from getting illness? And so that's the field of clinical health psychology. Okay, so the last slide was all Americans, and we talked about how age is a predictor of all of that kind of stuff. This is, I want to break this down for the Center for Disease Control, again, prior to the pandemic. For the CDC defined young as 15 to 24. Don't ask me why, it just does. And so this would be leading causes of death for young people. And so we're talking about people most likely in your cohort of students in this class. Number one is unintentional injuries, which again, we tend to call accidents. The main cause here would be motor vehicle accidents. So death from a motor vehicle accident. And we know from a lifestyle perspective, texting while driving is extremely dangerous. Virginia Tech has this whole program where they've got all of these volunteers who've been wired for video cameras in their cars, and they just go about their lives and they drive around, they do stuff, and eventually they get into accidents. And unfortunately, many of those individuals enrolled in Virginia Tech study, I'm a Hokie through and through, so that's why I'm talking about Virginia Tech. Go Hokies. Eventually, and unfortunately, some of those individuals are caught on camera, not only in their driving behavior, getting into accidents, but even dying in accidents. And they track their behavior and the safety things that they do, like use their turns. I hate it when people turn in front of me without using their turn signal. That's very poor communication. I'm sure those people have bad relationships. But anyways, doing safety things like using a turn signal before a turn, but then also doing hazardous things. And we know from that research, texting is the most hazardous. We cannot text and pay attention to the road at the same time. After that would be a touchless phone call. But even there, we're better than texting, talking and paying attention on the road, but that's still capturing some of our safety attention. We're much better if we are driving without talking with somebody, and definitely without texting somebody. And then very simple kind of behavior that's became law when I was a teenager, requiring safety belt use. That has made a tremendous impact on if people get in an accident, they have their safety belt on, they're a lot more likely to not be injured and survive that accident. And then nowadays we've got all these wonderful things in our cars, the airbags, the anti-lock brakes, all kinds of protective things that help us there. So young people, it is motor vehicle accidents, unintentional injuries. Some of these things in here would be things like somebody jumps off a bridge into a river and breaks their neck, that horrible kind of stuff. So it could be other kinds of accidents, not just motor vehicle. Suicide's number 2 on the list. And I can tell you, we've got several experts in our psychology department. We've got Dr. Kurt Michael, Dr. J.P. Jameson, where suicide prevention is their research, is their gig. And we are very woke in the clinical psych department on how to do interventions to prevent suicide. This is oftentimes untreated psychological or mental illness. So somebody who has an eating disorder, somebody who's severely depressed, somebody who has bipolar disorder, but they're not engaged in treatment with a mental health professional. That's a risk factor. Access to lethal means, like I talked about the firearms a little while ago. Homicide is number 3 on the list. And this is for all young people in the United States. But if you are particularly a Black male in an urban area that has gang activity, homicide in that demographic is the number 1 cause of death. So we get some different interesting geographic kind of things going on that in rural areas and suburban areas, we've got some differences than what we have, say, in urban areas in the US. Cancer's number 4 for young people, and then heart disease is number 5. A lot of this heart disease stuff is being driven by lifestyle behavior, inactivity, poor diet, youngsters getting type 2 diabetes, even at a young age, when it used to be more of a middle-aged type of phenomenon. Okay. So let's come up to what happened in 2019. So we call it COVID-19 because it began what we believe in December. Some of the Red Cross blood testing has found that in the US, there were some blood that was drawn or donated back as early as December 13th of 2019 that actually contained the COVID virus. So I'm going to stop my share here, and I want to show you a couple of slides that will give us a little bit of a feel for how quickly things changed from December 2019. This is a slide that is just looking at, we've just talked about leading causes of death. So let me get this on, let me share it. So hopefully you can see it now. And this is back starting in March 1st of 2020, and it only goes to April 27th of 2020. But I want you to pay attention up here. So remember, heart disease was leading cause of death, cancer leading cause of death, and then accidents after that. Let me play this and let's just watch. Here's COVID-19 down here. Play. Here we go. And I just want you to watch what happens in a time period of 2 months last spring. And remember, it was mid-March that we went totally online after spring break. We had that 2-week spring break. Look at COVID. Look at what it's doing. So these would be deaths because people were infected, complications from COVID as deaths. And so by April 27th, you see that we are at 2470. Okay. So now let me stop this share. I want you to know where we're at today. And I recorded this on January 8th. And this would be the Center for Disease Control COVID data tracker. And we are now, remember that was at 2,400 deaths. We're now at 21,259,000. I mean, total cases, and then deaths were at 359,849. Okay, let me go. I want you to know that you can look on the World Health Organization. So let me share this screen. And this gives us information about the disease throughout the world. And again, we use the term pandemic instead of epidemic because pandemic means it is all over the world. And that is going to have implications for us, particularly as we push out vaccines. And I'm going to talk about that here in a little bit. This is not just a US problem or a UK problem. This is a problem all over the world. And so it's going to take World Health Organization unity and cooperation for us to be able to finally try to end this pandemic. The current or the new, they're not in yet, but the current federal administration is going to rejoin the World Health Organization because the previous administration decided the US pulled out of that and we weren't cooperating with all of these other countries. So I'm glad we are going to be back in. The last, I don't think I need to show that. So let me go ahead, let me stop my share of the screen. Let me get back into the PowerPoint here. Okay. So here's where we're at by January 8th in terms of cases and then deaths from this. And keep in mind back in April 27th of 2020, we were only at 2,470, and this is where we're at now. So just like that interactive graph showed you how quickly COVID rose to being the leading cause of death last spring, and continues to be the leading cause of death. So when I talk about all of those causes of death, like, heart disease, cancer, all this stuff, we were talking pre-COVID. Okay, so let me go ahead here and get back into sharing this PowerPoint. Okay. I do want you to know that the North Carolina Department of Health and Human Services, which has been staffed by Dr. Mandy Cohen, as well as Governor Cooper and our legislators and our people in North Carolina, have certainly been cooperating. Actually, our state's been doing rather well. And I think Dr. Mandy Cohen, I've got such a girl crush on her. She has been the brains behind the management in North Carolina. Now, certainly we've gotten into some politics. Do we lock down and do we quarantine? Do we wear masks versus do we open up businesses again? And do we interact with others individuals? And so there's been some tensions going on there. Do we keep the school systems open? Do we keep them at full capacity or half capacity? In Watauga County, as an example, when they returned back to public schools, they had some kids, half of the kids Monday and Tuesday, the other half Thursday and Friday. I do want to talk about, I just want you to know about these resources. I'm not going to necessarily go into them, but I do want to talk about this term flattening the curve and what that was about. The point flattening the curve, if we look over here and we go, okay, if we look at our hospital beds and what we had available, keep in mind most hospital systems, Watauga County or Appalachian Regional Healthcare, Watauga County Hospital has expanded threefold in their beds, in their ICU beds, in order to take care of COVID patients, just as an example. And we've got a lot of healthcare providers who were normally practicing one form of medicine, nurses, doctors, physicians, assistants, who have been shifted over into caring for intensive care COVID patients in all of this. But if we looked at our healthcare capacity, and this is the level of our capacity, the term flattening the curve, if we had a huge increase in cases of individuals who were infected with complications, who needed hospitalization, particularly who needed ICU, intensive care, and particularly ventilators on intensive care, because there's a shortage of ventilators. If we had this many people at a time needing that healthcare, it would be beyond capacity. So people get turned away. As an example, like, you know, your grandma needs to go to the hospital to be in intensive care and might get turned away because there's no bed space for her. There's no, and it's not just the beds, it's the personnel taking care of the human beings in the beds. So the term flattening the curve was trying to slow the spread of infection, to keep the number of cases down here where the healthcare system, the capacity of the healthcare system, and then even like the morgue system. I mean, there are places where in New York City, they're burying people in mass graves. Even there are places where they've got refrigerator trucks where they're just trying to safely store dead bodies of individuals. I know this stuff is morbid, y'all, but I'm talking the truth here. I'm talking about what's going on in our country right now. So in here, it's like flattening the curve means being able to slow the spread so that the healthcare center can take care of this. This has also been really good in terms of being able to have enough tests for people to have access to tests, flattening the curve. It has also been really good, and I want you to watch the Netflix Race for a Vaccine. We have had amazing progress in vaccines, so much more quickly than I ever anticipated, and they're so much more effective than I ever anticipated. So flattening the curve, buying us time for the science and the testing, the science and the vaccine, keeping the curve down low enough so that a healthcare system could have capacity to take care of people in need. That's what flattening the curve has been all about. I had a whole course in epidemiology as a graduate student. I'd never heard the term flattening the curve until this pandemic, and now it makes a lot of sense to me. I want you to know that our local health department has really been on this well. We're in a rural area, but they have been fantastic. Know that UNCTV at times offers updates. Governor Cooper, Dr. Manny Cohen, she's actually moving up to the Biden-Harris administration. She's been so good in helping North Carolina manage the pandemic that she's been pulled up to the federal government. This would be Appalachian Regional Healthcare Departments, how to protect yourself. And you all know this. I know you've been bombarded with this over and over and over again, but I want us to pay attention to these recommendations. And then I'm going to show you a little bit of data that sort of suggests that, yeah, these recommendations are good in protecting people, but they're not perfect. Okay. And also keep in mind, there are a lot of people, we've had some very interesting responses in human beings based on their politics during this pandemic, where we kind of have, and I scratch my head and I shake my head. There are people who have no problem with wearing masks and social distancing and being courteous, careful for themselves and courteous of others. And then there are people that absolutely are they're anti doing those kinds of things. So the social distancing, and you all have heard the 6 feet, but what we're going to see is 6 feet is protective, but 6 feet is a bit random in that number. Frequent hand washing. I have never had so cracked over time. I moisturize, I wash and clean, sanitize and moisturize, but it's just like, whoa, it's hard to kind of keep especially these hands nice and moist during the winter. Covering cough or sneeze, ideally ideally with clothes within the arm, but not sneezing out in the open. Keeping distance from others who are sick, avoid touching your face. I think many of us have been on a very interesting experience since last March of realizing, boy, I like touching my face and scratching things and rubbing my eyes and that kind of thing. And so working really carefully to try to not do that kind of stuff. And then doing things like disinfecting high touch areas. So common areas like doorknobs, remotes, light switches, tables, handles. We've learned over time though, that it's much more likely for people to become infected, not by necessarily touching stuff and then touching face and infecting themselves that way. I was pretty anal OCD at the beginning of the pandemic, disinfecting doorknobs and the refrigerator door and the door handles in the kitchen and just everywhere. And over time, I've kind of relaxed that a little bit. It's not that they're gross or anything, but we've kind of learned that there's a lot less danger in that than the aerosol kinds of forms. Okay, so big changing patterns in the last 120 years, and particularly big change starting last December. So let's talk about a little bit of background on the actual virus. Is a SARS and it's a COVID number 2 that is the coronavirus. That is the virus causing the disease process called COVID-19. So coronaviruses is a large family of viruses that tend to infect birds and mammals. And so birds, bats, mammals, that kind of thing. And they're usually, historically, they've been more respiratory in nature, although we're seeing this SARS-CoV-2. It's got a respiratory piece to it, but it's got a lot of other kinds of disease processes that it's driving: blood clots, weird circulation, things to toes and feet. We're having people having to have feet and legs amputated because of this. Some really weird immune system responses, these cytokine storms that poison people and kill them. So again, historically, these viruses were more respiratory, but this new one's a new breed. So SARS-CoV-2 translation, severe acute respiratory syndrome coronavirus 2. So it's a sequel to the SARS coronavirus that happened in 2022. It is also a sequel to the MERS virus, which was one of these viruses that happened more in the Middle East in 2002. These viruses are thought to jump from bats to humans. Sometimes it's a bat that bites a human, so little vampire bats bite a human and infect. The bats carry these viruses, but they themselves usually are not sick. Okay, so they are vectors. They're carrying a virus and they're sending it to something else, but they're not necessarily sick and dying from it. At times, this goes through an intermediary organism. So it doesn't go directly from bat to human. It goes from bat to one hypothesis early in the pandemic was that it went to a pangolin. Here's what a pangolin looks like, where thinking that what happened in Wuhan, China, was there are a lot of open meat markets, and that is absolutely necessary for people in rural areas to get their food. They go to these open markets where there's dead meat that is not like the US that's in, well refrigerated in a grocery store, count your blessings. That's how we can get our meat very safely that way. And the thought was that the bats had fed off of these other animals like the pangolins, and then human beings ate the pangolins that were kind of rotting in these open markets and then got infected that way. The pangolin transmission has been questioned though. So I just want to let you know, there's still a bit of mystery of how this jumped in Wuhan from the bats. We knew it was in the bats because I'll talk about how EcoHealth was tracking the bats. So just to kind of clarify here, the name of the virus is the SARS-CoV-2. It's the virus that causes this disease that we call COVID-19. And it's much like the HIV, the human immunodeficiency virus, HIV virus, could cause, without treatment, now we've got really good treatments for this, could cause the disease process, acquired immunodeficiency syndrome, that we knew as AIDS. So this was the virus, this was the disease, this is the virus now, and this is what we call the disease. And it got named COVID-19 because that's when it was first identified. So prior to pre-COVID, where we've had this rapid takeover of this infectious disease and this pandemic, and it's been the leading cause of death since the end of April in the United States of last year, 2019. Prior to that, there was a decline in infectious disease. There was more chronic disease, chronic meaning people had it for a long period of time. When you have a disease for a long period of time, that is continued drain on the healthcare system. There was a lot more lifestyle influence in the disease and a lot more disease revealed in the elderly. And so one way of thinking about this is that pattern was putting more demand on our healthcare system and a lot more expense on the US healthcare system because of these dynamics here. Okay, so the factors that changed the pattern. So let's talk about what happened between 1900 and 2019 and why we went from infectious disease to lifestyle-driven disease there. Immunizations did a lot for us to tame childhood communicable diseases. So I never had polio. I never had measles. I did have chickenpox as a kid. My kids got vaccinated against chickenpox. I never had diphtheria as an example, and most of you all haven't either because you had those childhood immunizations that have kept us from getting those diseases that killed people between 1900 and 2019. A lot of us like to think about high-tech stuff like the development of antibiotics and that kind of thing, but it was actually some really simple public health kinds of things in the US. Sewage sanitation, keeping our poop out of our drinking water, water purification, again, public health, getting us clean water. Most of us in the United States, count our blessings, have had access to clean water. Third world developing countries, this is still a big issue for a lot of people in these developing countries. They don't have access to clean water. Because we have clean water, we're a lot less likely to get disease from our drinking water. Cheers, drinking water. Another thing that has happened over that time period, we got better at food preservation. We were able to develop refrigeration systems. There's up and downside of food preservatives because that allowed people to eat food without getting sick. But now we're seeing in processed foods that have a lot of food preservatives that actually creating harm again for people. But refrigeration has done wonders. Behavioral lifestyle change. People, once we had motor vehicles, and then I even laugh, like, like in airports, they're people movers, they're escalators in malls, that kind of thing. People became a lot more sedentary. They exercised less, they moved a lot less. Our diet changed, a lot more reliance on animal products, even social changes and many of you in here, because you have the privilege of getting at least a bachelor's degree and becoming a professional, you are likely going to move away from extended family because you're going to go where those professional jobs are. Back in 1900s, people would be born and raised and worked and married or paired up with others and died in the same community. There was a lot more of that sense of community. And then a lot of preventive healthcare, as example, being able to get immunizations, being able to get cancer screens like mammograms to screen for breast cancer, that kind of stuff. So you all, we are living in history here. Okay, you are living in history here that 2020 absolutely changed the world. This pandemic has changed the world. And the cool thing is hopefully this will be over at some point in time and we will have great stories to tell our, maybe not great, sad in some cases, but we'll have stories to tell our grandchildren and our great grandchildren, should you have them. So let's ask from a public health standpoint, were we prepared for this pandemic? And this is where I talk about how, and you can't help but get political here. This is where some of our sister countries like Germany and Sweden and some of our Asian countries, where the insurance and the public health were more coordinated, they did a much better job of managing this pandemic early on. Now, many of those countries have had resurgences, and so nothing's been necessarily perfect per se. But we in the US, we really struggled to kind of catch up to what we needed to be doing. So if we say no, the timing of when we kind of kicked in paying attention to this after we knew about what was going on in China, Dr. Anthony Fauci has said no, we were not doing the right things early enough. We were basically, because of the Gates Foundation, so this would be Bill and Melinda Gates and their foundation, they were on this. They'd been tracking those SARS viruses and they were on this. And then some of our pharmaceutical companies like Moderna, Novia, Pfizer, AstraZeneca, Bentex, those companies were already looking at the genome that was extracted from those bats in China from EcoHealth. And they were taking those genomes for those different SARS viruses and begin doing the starting process to develop vaccines. So some of us being able to get these effective vaccines so quickly is because some of this homework was already being done by these pharmaceutical companies. Homework was being done by the Gates Foundation funding these things. And then there was this organization called EcoHealth. And Dr. Peter Daszak was, he's a US individual, but he spent a lot of time over in China with his team, and they were monitoring on a cyclical basis. They would catch these bats, swab these bats. I want you to watch this on that next Netflix Explained. They do a really good job of explaining this. They were monitoring the viruses in these bats so that they could predict what could possibly spin out and go from these bats to either the intermediary, the animal, to the human, or directly from the bats to the human. So we had a leg up on that because of this organization. Now, interesting in the, which will now be the previous administration, they had funding from the National Institute of Health. So our NIH, based on our tax-based dollars, was helping to fund EcoHealth to be able to watch these bat viruses, collect those genomes, being able to predict what might be happening in humans, what we might be vulnerable to in the future for developing treatments and developing vaccines. In an unprecedented move in the previous administration led by Donald Trump, he had NIH cut their funding. And so it's going to be interesting to see if here in the near future, if we are able to refund EcoHealth so that we know, because this scares the bejeebies out of me. We need to know what could be spinning out. We need to know. It's kind of like the flu every year is a different strain. That's why we watch the winter on the other side of the world and what kind of strain goes through those populations in the other hemisphere to be able to predict what kind of flu strain is likely to be happening in our winter to develop vaccines so we can get vaccinated for the flu every year to try to prevent from getting the flu. Like, you need time. You need to know what those viruses and what strain, what kind of genetics in those strains are. So please do watch the Netflix Explained on that. When it came to the United States being prepared to have enough personal protective gear, so the N95 masks, all of that gear for nurses and frontline workers and physicians, we did not have enough production of that. We did not have enough ventilator production ready to go for hospitals and intensive care units. We did have a leg up, and again, this is because of private pharmaceuticals. The only FDA approved drug is remdesivir, and that is been known to be effective for people who are infected. And then we have had some leg up on being able to isolate the antibodies of people who have been infected. And then Regeneron, certainly been some high-ranking individuals who've been affected who were given Regeneron, which is the antibodies of recovered individuals. This has not been FDA approved yet. I'm sure it's on the horizon, but being able to collect blood for people who've been infected, isolate their antibodies and give them. So overall, the US actually was not very well prepared. We could have done better. My hope is that we return to relying on scientific evidence a bit more here in the near future. So the pattern post-COVID, a dramatic takeover in infectious disease. And again, it was, we believe to be zoonotic transmission, which was when it goes from the bats to another animal, then to the human beings, but that's still being debated. We're not sure. The pangolin seems like it's been ruled out. There have been some concerns that it transmitted in a snakefish, this funky looking thing down here. There's even speculation on ferrets and cats. They're still debating that. What has been resolved though, and what was accused, is that this institute over in Wuhan, part of EcoHealth, they would collect the bat viruses, they would bring it into this institute so they could study it. There was speculation at one point in time that this was a man-made virus that was deliberately released out into human beings. And that has since been refuted, because the genome that would have been human made is not the genome in the infection that is happening. So that has been ruled out. This was not a man-made virus. This was not a terrorist attack, the Chinese trying to run humankind in a pandemic. Now, going back to the safety behaviors that we've been talking about all the time, the social distancing, 6 feet, the wearing the mask, all that kind of stuff. I want us to look at the scientific data, because remember I told you, yeah, that stuff is good. It improves safety, but it's not perfect. And here's why. When we cough, there are over 3,000 droplets expelled in a typical cough that can travel 50 miles an hour for 20 feet. 20 feet, okay? Remember we're doing the 6 feet thing? A sneeze, 30,000 droplets can travel 20 feet up to 200 miles per hour. A sneeze is very powerful. A breath, just a simple breath, 50 to 50,000 droplets. When we are speaking, 500 to 500,000 droplets at a single speaking something. And then when we're singing, remember hearing about that choir where they, so many of them, they were singing together early in the pandemic, and the singing really projects their voices. And how many of those individuals got sick. This has made me reflect on the fact, you all, I used to teach in, back before when I was live, I would teach in 114 in the library, and I've taught in IG Greer, and I can project my voice. So I would not use the microphone. I would not use the lavalier, that type of thing. But in order to project, in order for people, say in IG Greer, to be able to hear me up in the loft or hear me in the back of the room, it's made me realize, this is so gross, how much I was spitting on my students, like especially students in the front row and in those front rows there, how much I was just spitting on them all the time. It's like, that is so gross. So at least you all are protected behind your computers. I'm not spitting on you while I'm teaching into Zoom. I don't know if life will ever be the same after us realizing some of this kind of stuff. Let me go back. Oops. Okay. Sorry about that. So our vulnerability for infection is simply our exposure to somebody else who has the virus times time. So limiting exposure is another safety thing that we have been encouraged to do. I know I have learned, I mask when I go grocery shopping, and I get in there and I get my stuff and I get out of there. And there's no lingering and looking at labels and thinking about, oh, what recipe can I make with this fresh vegetable that is, on special, that kind of, none of that anymore. Get in, get out. I want to talk about R naught. R naught is the number of new cases any one case can create. So one person on average, the CDC has calculated, this was back in 2020, on average between 2 and 3. Now, there are concerns that we've got a new variant that may be more contagious, maybe not more deadly, but maybe more contagious. So the R naught from this new variant may be larger than that. It could be that every single person who has it has the potential to infect 4+ people. But this is just a way of getting an idea of how virulent or infectious has the virus been. Incubation period is the period of time in which a person has contracted this infectious load of the virus and the onset of symptoms. And 95, the majority by 14 days. Some people start seeing it within 2 days, 50% by 5 days, which is why if you get tested and you test negative, you are still supposed to be quarantining for a certain amount of time, just in case you're infected, but the test came back a false negative. So the infectious period is 2 days before the onset of symptoms. And some infected people are totally asymptomatic. This has been a weird thing about COVID-19, that in the past, like if you were infected with the flu, you had the flu. You might have had a mild case, particularly if you'd had the vaccine, but you got sick. You knew you were sick. You knew to stay home. You knew to go to the doctor, that kind of stuff. And in this situation, there are a lot of people who've been walking around who are asymptomatic, who are spreading. They are, like typhoid Mary. There's typhoid Mary. That's the woman who was not sick, but she was spreading typhoid to others. And it can last 10 days after the onset. And then we can be infectious 3 days after fever and reduce symptoms. So there's just a big window of time where people can be infected, can be spreading it. And in fact, we're more likely to spread infection before we ourselves, when we are infected, are sick. So in that period where we can be asymptomatic before we get sick, that's when we've got the highest viral load and we're most contagious. So some of this is kind of an explanation for why it has been challenging to contain the spread of infection with COVID-19. So the most common transmission, we have learned this over time. Like I said earlier, like the surface, the fomites, the surface is a little less likely now that we've been able to study this over time. The most common way people get infected, contact transmission, so direct contact with an infected person. So nurses, doctor, nursing home workers, who are people at home who are directly caretaking for people who are infected. This could also happen from a handshake with somebody else who's infected and then touching your face. And then droplet transmission. So direct inhalation of an infected person's droplets, usually within 6 feet, which is why we do the 6 feet kind of thing. But like you saw in the cough and the sneeze and the sing, it can go further than that. It's got the possibility of going further than that. So this would be inhaling through our nose, inhaling through our mouth, contact through our eyes, contact through our hands, and then touching would be more of that droplet transmission. That airborne transmission that's occurring here, again, most common, could be infected droplets suspended in the air for hours. That is more likely in enclosed spaces. It's more likely in a prolonged exposure. Again, like I don't linger in the grocery store anymore. I get in, get out. We live so far out, we're not able to have delivery here of groceries. And then inadequate ventilation. And so if you have to be enclosed for more of a period of time, and I know a lot of gyms are doing this as an example, ASU has moved their ventilation. They were recirculating air to save energy. In all of the ASU buildings, they have stopped doing that. They have started pulling outside air in to improve ventilation within the buildings on our campus. Run fans. If you have to be riding in a car with somebody else, it's best to be masked if you do not live with that person. If you can be masked and you can have windows down and have some circulation in the car, that's better. This is part of the reason why we've been concerned about winter. I know with some of my very careful family contact over the holidays, we did our best to eat outside and the weather was able to cooperate. But if we all have to move inside for those kinds of things, that's where it gets more dangerous, as an example. So the phone-like transmission would be the surfaces to fingers to face. This we now know is rare. It doesn't mean we shouldn't stop washing our hands. It doesn't mean we shouldn't stop sanitizing things like doorknobs and that kind of thing. But it is less common to contract this than this stuff up here. Okay. But the scary thing is this virus is pretty hardy. They found on cruise ships where they went and they swabbed and they tested cruise ships 14 days after people had disembarked on the cruise, when there was infection going around on the cruise, they still found active virus on surfaces. So it is hardy. It can kind of live on surfaces. So in all of this, behavior is key to transmission. Okay. So I want you to see the handout, how to avoid on As You Learn. And then this one's kind of interesting here. And this is, it's kind of sad, but most people who have become infected, minus these super spreading events, most people are in their homes and somebody brings it into their home and infects them that ways. So this is why you hear about, like a whole family getting infected. This is why it's been really dangerous for people in nursing homes. It's why people in nursing homes have been prioritizing vaccine. People who are in jail, who are in these contained spaces, where somebody else brings the virus into the home and infects them. Public bathrooms tend to be high touch areas. And this is really gross, but we're going to talk about poop for a minute. They are actually studying at ASU now. They've been doing this at some other universities. They're studying and testing the sewage on campus and in our town, because the sewage tells us how much virus is being shed through people's poop. And so it's a backwards way of estimating how common the infection is in the community by testing the sewage material. But the gross thing about this is when a person is infected, they shed the virus in their feces. And we know, particularly toilets that do not have lids, this is part of why I'm glad I'm not back in Smith-Wright this semester. None of the toilets in Smith-Wright have lids. So if somebody took a poop, and we know from spread, when a person flushes, it aerosols virus from an infected person's feces into the air where people can breathe it. So one safety protection you can do to help with this, I know we did some traveling in our camper over the holidays, and the camper stuff is really safe, but there were some times where it was necessary, at least on the return trip home when we didn't have our tanks, to use a public bathroom. Mask for a while before using a public bathroom. Sanitize your hands. When you get back to your vehicle, sanitize your hands. Keep that mask on for a while, just in case there has been any aerosol released from feces. And then the scary thing again is that 44% of infected people can be asymptomatic and can be shedding the virus for days, which again is why it's been kind of hard to keep track in some cases with this virus. And then we're most contagious just before the symptoms begin. Some of the super spreading events, things like meat packing, weddings, funerals, birthday parties, religious gatherings, sporting events. Those are some of the rallies, the political rallies, that kind of stuff. That's where they're called super spreaders, because it can just go from person to person very quickly. Okay, so we've talked about all of this stuff, the social distancing, the hand washing, careful with the face. She's about to do a really nice job of how to cough into her arm. Okay. And let's talk about vaccines. There's one more that is going to hit the market pretty soon, but let's talk about the ones that are out there right now. The Pfizer BioNTech vaccine, 2 injections, 3 weeks apart, 90% effective. This is a derivative from RNA virus code on the top of that the coronavirus. It has to be stored very, very cold. And so that's a downside of the Pfizer. Moderna, 2 injections a month apart. And a lot of people are getting some really nice immunity after that first injection. 95% effective. That is amazing. What a blessing that has been for us. Again, it's an RNA virus. The nice thing about this one is it has to be stored cold, but not nearly as cold as the Pfizer vaccine. The Oxford AstraZeneca, 2 injections a month apart. It's only 70% effective. But we think AstraZeneca is going to save us in these really rural or frontier or developing countries because it only requires regular refrigeration. So let's say really remote North Carolina or remote Africa, more likely to have success getting people vaccinated from this vaccine. 70% will provide some good protection, but it can be transported with a regular fridge, whereas a lot of these rural frontier developing countries do not have this source of refrigeration to safely push out these vaccines. Now, I want to compare this because when I saw the original data of 90 to 95% in these two vaccines, I got so excited. And the reason for that is that the typical success of an annual flu shot, which most of us, when we go get a flu shot, we tend to get them late fall, early winter, because you see flu lives in the flu virus tends to, different strains, but tends to live well in dry air that is cold air, which is why we see more flu than, say, summer months when we've got moist, humid, warmer air. Only 40 to 60%. Only 40 to 60%. So people getting the flu vaccine could get the flu, but they tend to get a mild case if they've been vaccinated. But a lot of times individuals who were exposed to flu absolutely don't get the flu, but only 40 to 60. And look at how successful that is. So really wonderful. And this is usually an inactivated virus. So these are our vaccines. This is going to be the hope for us. So I want to talk about health behavior here. The contribution of behavior to our health prior to COVID was 40% of our health status was determined by our behavior, only 10% by our medical care. But keep in mind, access to medical care, we tend to have the haves and the have-nots in the US. I am fortunate to be a have. I am very fortunate to have insurance. When I was raising my sons, if my son turned his ankle in a soccer game and it could not stand on his ankle, I did not have to, well, first I got him into the orthopedic office because it's cheaper to get x-rayed there than the ER. But I didn't have to sacrifice food for my family because I needed my kid to get his foot x-rayed. A lot of people do. A lot of people have to make those really, really tough decisions because they do not have good insurance. They do not have access to healthcare. Other factors would be the region in which you live, or the job you work. My grandfather was a coal miner all his life. That was the only job in his town. And he got black lung and eventually developed cancer from his black lung and died, basically consequences from coal mining. My job, on the other hand, is very safe. I do not work in the coal mines. And so other unsafe jobs would be like police officers. Other factors would be our race and our vulnerability for violence based on our region in which we live, the race in which we are, the color of our skin. And then genetic factors here too. Now, keep in mind all of this was behavior on our health status pre-COVID. We do not quite know what contributions of behavior will fall out statistically until probably after this pandemic. So the main health behaviors beyond the protective health behaviors to prevent COVID-19 infection in the United States, and I've already mentioned this, would be the tobacco use. And I've got smoking down here. I really should have smoking and vaping, as well as tobacco chew. If we could change one behavior in the US to make the greatest impact beyond the pandemic, it would be to get everybody using tobacco products to stop using tobacco products. We've got an interesting thing that is happening in history now with legalization of cannabis in a lot of the states in the United States. And I'm definitely against criminalization of that because actually alcohol, which is legal for people over 21, causes so much more harm in the United States than people using cannabis. But we're seeing an interesting thing happen, more consumption, easier access and consumption of cannabis that could have pros and cons for people's health. And it'll be interesting to see how that pans out. Number two, people don't move enough. They don't exercise enough. They don't move enough in our culture. And so sedentary lifestyle, the magical thing, and we've got a whole lecture on physical activity and exercise coming up, as well as a whole lecture on the tobacco stuff this semester. So don't worry about these numbers so much right here. I'll be covering this throughout the semester. Nutrition is complicated, but in general, we're consuming too many animal products, too much fat, saturated fat and cholesterol. We're not consuming enough fiber. We're not consuming enough fruits and vegetables. And you're going to see in the Walsh American Psychologist article, I'm going to teach that article, but I want you to read it. I love that article, the way it simplifies things. I love that he calls it the rainbow diet. There is a reason why we have evolved to see in color, and that is because across our evolution, we had to see pigment to know what foods were the healthiest for us. And so rainbow diet. And then alcohol, again, more harm comes out of alcohol from a public health standpoint for us in the US than from cannabis use. All right, that is the end of part 1 of the intro lecture. And so I am going to now record, get this loaded up onto As You Learn. And after you watch this, please go ahead and move on to part 2.